Transplantation means replacing a diseased organ or a part or even a simple tissue. We can call it as transplantation. Now, if we look at the human history of transplantation, notable mentions can be found about, like in 1550 BC, about grafting of skin on burnt tissue itself. Furthermore, if we look at our Indian history, we can find about 600 BC, Susruta does mentions about full thickness skin graft. Similarly, many history can be found about transplantation of organ. Coming back to modern medicine, notably during the world wars, skin transplantation was done predominantly on the soldiers who were injured either with burn injuries or other injuries. However, the first renal transplant was done by 1933, but most successfully it was done on identical twins by 1953. And now, over the last decade, we have indeed come a long way in relation with transplantation. Now, let us get some basics. First is the definitions. We can classify transplant based on what kind of transplant it is. We can call it as an autograft or auto transplantation. Auto means it is from the same body. If we take the organ from the same body and replace it there itself, we can call it as autograft. A very important part of this is called as autologous blood transfusion. I think you must be aware of the various infections or the potential complications of blood transfusion. Now, today, as of today, blood transfusion is again considered as a organ or tissue transplantation. A very safe way we can prevent the complications of blood transfusion if we collect the blood sample from the patient himself or herself prior to the surgery, and when after we need to transfuse blood, we can transfuse the patient's own blood. That is called as autologous blood transfusion. And this helps in prevention of most of the complications related to blood transfusion. Similarly, another example would be a bone autograft. Many a times, the patient may get involved in severe trauma-like situations, especially with road traffic accidents, and we can have committed fractures of the limbs, where there is a definite gap between the fractured areas. And many a times, this lead to non-union of the bone itself. So what we can do is we can take a small piece of bone from elsewhere in the body, place in that area so that the bone healing can be done. This is called as autologous bone grafting. Moving on, there is something called as Xenograft. Xeno means when completely unrelated species organ is used, we call it as Xenograft. Now, what you must understand is there are many complications with transplantation. Many complications can be alleviated if we go for something called as allograft. Allograft means when we use the graft or the donor is from the same species, that is from one human to another human being. Now, this allograft can again be classified into many ways. For example, we can call it as an isograft when the donor is an identical twin. So, most of the complications related to the immunological consequences can be avoided. Similarly, there are two other type of transplant. One is called as split transplant. What is a split transplant? If you do actually go through the news, you can find that many times organs are harvested from many brain dead patients, and these organs are used for transplantation in many patients. So, when the organs from one patient is used for transplantation of many patients, we call it as split transplant. Another type we can say is called as domino transplant. Now, what domino transplant is? For example, a patient is having a disease called as cystic fibrosis. Now, cystic fibrosis will eventually damage both the lungs, and because there is damage to both the lungs, there will be certain cardiac complications also because of the pulmonary hypertension, etc. So, in domino transplant, what is done? when these patients are undergoing transplantation, we not only transplant the lungs, but along with that, we can also go for transplantation of the heart itself. This is called as domino transplants. Now, coming back to the sources of the organs, we can easily classify either the source of the organ could be a living source or a dead source, or commonly called as the cadaveric source. Living source, I think you have heard about this. When a person donates one of the two kidneys to another patient, that would be a living donor. And when the patient becomes brain dead and his or her organs are harvested, we call it as cadaveric transplant. Now, what are the common organs which are transplanted? Now, if we look at the common organs which are transplanted, we can find organs like heart, kidney, liver, lung, pancreas, bone marrow, intestines, cornea, and skin. So, as you can find, there are many and various types of organs, which we actually classify into two types. One is called as solid organ transplant, another is called as the stem cell transplant. Now, when we say solid organ, that means the organ itself is transplanted or part of an organ. For example, it would include like a pancreatic transplant or transplant of the islet cells, or a corneal transplant, heart transplant, intestinal transplant, kidney, liver, lungs. All these we call it as solid organ transplantation. Then what are the stem cell transplants? I think you've heard about many kind of hematological disorders, and these disorders can be cured with stem cell transplantations. So the reason why it is divided into two parts is there are two aspects of it. First, let us consider about the stem cell transplantation. So in stem cell transplantation, very simply what we can say is, first we kill off all the hematological cells of the recipients, and then we introduce the stem cells of the donor into the recipient. So there is a big fraction of time when the patient is completely deficient of any immunity of the patient's own self. That means the patient remain immune deficient for a prolonged period of time. Whereas when we look at the solid organ transplants, there are two phenomena which may happen. The first phenomenon which can happen is, because the organ is from another patient, the body may not accept that organ, cells of that organ, and the immune system of the body will act upon the organ. Okay. Other way around, the immune cells of the solid organ can mount an immune response against the body itself. That is also called as the graft versus host disease. So these phenomena could be seen in case of solid organ transplantation. Okay. Now, why are we discussing about post-transplant infections? Well, in case of successful transplantations, we do have many adverse situations, and a very notable adverse situation actually comes after the successful procedure of transplantation. That is mostly related to the infections. Now, before moving on, what I want to highlight in this picture is, if you look at the graph showing the number of the transplantations that has happened in India over the past few years, and we can find the numbers are increasing steadily. That means as of now, there are a huge number of patients who have actually undergone transplantations. Now, what are the major risk factors with transplantations? Obviously, we can find most important is related with the organ itself. That means the organ and the tissue matching must be done, including not only the blood grouping but also HLA matching. Furthermore, other complications can be related like infections and complications with the surgery itself. Furthermore, during and after the process of the transplantation, the patient is given many kinds of drugs so as to suppress the immune system. These drugs will have their own adverse reactions itself. So these are, in a very gist, the many kind of risk and complications a recipient may face. Now, coming back to the immunological complications, as you can see in this picture, the most notable reaction that can be seen is called as hyperacute rejection. That means if the donor tissue and the recipient tissue are having mismatch in the blood group or the HLA type, then we can find something called as hyperacute rejection. That means the body rejects the organ itself. And if we are able to prevent that, after some time we can find something called as acute rejection. That actually happens within days to months, in which the body starts reacting against the grafted tissue. And this can be alleviated with immune suppression of the recipient. Nevertheless, even if we are still able to achieve that, chronic rejection eventually sets in, which actually occurs from months to years after the transplantation. So, this is one of the very important complications that the patient may end up in this. Now, to alleviate all these things, what we can do is we can go for matching of the tissue, blood group, etc., so that we can prevent the hyperacute rejection. And as far as avoiding the acute rejection, we can put the patient on immune suppression using various kinds of drugs. If the patient is immune suppressed, it will not be able to mount an immune reaction on the grafted tissue. And we have to maintain this suppression of immunity for a prolonged period of time. That means from days to months. And during this time, we also have to look for the various signs of graft rejection or many parameters which helps us in identification of rejection of the graft itself. Now keep in mind, the timeline over here is from days to months. And this is the actual period where the patient is immune suppressed and are prone to various kind of infections. So, what could be the eventual complications? We can find toxicity with the various kinds of drugs immediately. Then, in the stage of the immune suppression, we can find various infections caused by various organisms, be it community acquired, be it hospital acquired. And finally, we can also find many kind of malignancies resulting from the resultant immune suppression. But furthermore, if we look at the normal or the human microbiota, the eventual process of transplantation does affect the microbiota. Not only the procedure itself, but also the various drugs and the immune suppressive agents which are used. This lead to what is called as microbial dysbiosis. And this normal microbiota plays a very important role in finding out the eventual fate of the procedure. If the dysbiosis fails to restore to the normal microbiome, there are high chances the patient will have various kinds of infections and also graft rejection. But if the microbial dysbiosis reverts back, then we can find that the graft acceptance can be there. Now, coming back to the various organisms which can cause infections, especially in the post-transplant period, we have organisms like, as we can classify them into viruses, which may include the herpes group, hepatitis group, the retrovirus. Other viruses include the West Nile, chikungunya, Zika viruses. Among the bacteria, notably, we can find the various gram-positive and the gram-negative organisms. And a very important cause would be the mycobacterial diseases, not only tuberculosis, but also NTMs. A very important aspect of infections in the post-transplant period are the fungal infections. Now, these fungal can be caused from various species like Candida, Aspergillus, Cryptococcus, or geographical fungi like Histoplasma, Blastomyces, depending on the geographical location of the place, and including opportunistic mold which may cause infections. Finally, we can also find various parasites which may cause infections like Toxoplasma, Trypanosoma, Strongyloides, and even. Now, if we again classify these pathogens, we can easily classify them into two ways. The first part, we can classify them as nosocomial exposures, and the second one is community exposure. Now, why this is important? Because immediately in the post-transplant period, the patient actually remains in the hospital for a prolonged period of time. So, in this time period, the patient may have infections acquired from the hospital itself. Now, if we are able to prevent those infections and the patient is eventually discharged and the patient goes back to his or her home, then we can find infections caused by organisms which are predominantly present in the community. So depending on where the patient was present at the time of acquiring the infections, we can also decipher what are the possible causes of the infections. Thus, we can say either nosocomial or community exposed. Another important question is why these patients are more prone for infections. If you see this chart, we can find various causes. Well, immune suppression is a very important cause, that is true, but other than that, we can many other causes also, like prior therapies, especially patients undergoing stem cell therapy, where all stem cells are ablated in the recipients. Then mucocutaneous barrier integrity. Now, this immune suppression and various surgeries may lead to lack of integrity of the mucocutaneous barrier, leading to mucositis and eventually deep infections, including sepsis. Again, various drugs which are used may eventually lead to neutropenia, lymphopenia, or even hypogammaglobulinemia. All these are actually the protective functions of our immune system. Next, what we can find are some technical complications relating to the procedure itself. It may involve the graft rejection or even lack of hemostasis or immune reactions. The patient may have an underlying immune defect, or the patient may even gain some of the infections from the donor tissue itself. A very important notable cause would be cytomegalovirus. For example, if the donor was actually infected with cytomegalovirus, even remotely in his history, some of the solid organs like liver or the kidney may even harbor the virus itself. And after the transplantation is done, the recipient may end up getting the infection from the grafted tissue. Now, if we go through the various drugs which are used in the whole procedure of transplantation, you can find many drugs are used. And each of these drugs will have a separate effect on the body itself. For example, anti-lymphocyte antiglobulins may activate the latent virus like herpes virus or varicella. Plasmapheresis may lead to infections with bacteria which do have capsules. Corticosteroids, again, they may cause bacterial and fungal infections. So if we look at this whole chart, we can find almost all of the drugs will have some effect directly or indirectly leading to more propensity for infections. Okay, now let us look at the timeline of the infections. Now this is again very important because not every type of infection actually occurs immediately or after a certain period of time. If we do a timeline analysis, what we can find is, for example, in this chart, various viruses which does cause infections, we can find in the immediate post-operative period, that is in less than 4 weeks, what we can find are the viruses, viral infections are acquired from the donor tissue itself. But other viral infections actually occur from about 1 to 12 months. That means after about 1 month of the procedure, other viral infections may be acquired from the nosocomial environment or the community, or from the community. People may end up getting these infections. Most notably would be the herpes group of infections, cytomegaloviruses, Epstein-Barr virus, hepatitis B virus. These are the very common infections which can be seen. Similarly, if we look at the timeline of the fungal infections, over here what we can find is in less than 4 weeks, that is the time period the patient generally is associated with the hospital environment, we can find the various infections caused by Candida species. This Candida species generally is associated with the hospital environment. And thereafter, when the patient is discharged, we can find various type of community acquired infections, which may include aspergillus infections, cryptococcus, or endemic fungi. Similarly, if we look at the bacterial infections, again in the immediate post-procedure period, we can find various kind of bacterial infections ranging from urinary tract infections to wound infections or line infections. Most of them will be caused by nosocomial organisms which are present in the hospital environment, and most only these are healthcare associated infections. However, again, when the patient goes back to his or her home, then we can find various community acquired infections. Now please take a note of these infections. What we can find are some of the very uncommon infections like listeria, nocardia, and mycobacterial diseases. So these are the bacterial infections are more commonly associated in the post-transplant period, ranging from about 1 month to 12 months time period. Finally, if we look at the parasitic infections, although most of the parasitic infections can be controlled in the immediate post-transplant period, later on we can find various infections which may range from strong allergic infections to toxoplasma infections. Now, having said that, this about the timeline, why this is important? Because when we are actually examining the patient, the time period of the transplantation procedure becomes very important because we can uh, narrow down the various differentials of the organisms which may cause infections in these patients. Now, moving on, next comes a very important question: how we can prevent these infections in these patients? We can categorize them in three parts. What are the things we can do before the transplantation procedure? What are the things we can do during the procedure? And what are the things we can do after the procedure? Now, before the procedure, first what we need to assess is we need to take a very detailed history of the patient. And this would include important points including occupational exposure, hobbies, and drugs, and even sexual history. And this will enable us to identify what are the possible organisms the patient may have been exposed to, so we can detect even the latent infections in these patients. Next, we have to do a series of investigation in the recipient. What are those? The important investigation would be included the viral profile, including cytomegaloviruses, Epstein-Barr virus, the measles, mumps, rubella. Sexually transmitted diseases would include syphilis, HIV, hepatitis serology, and toxoplasmosis. A very important investigation is latent tuberculosis. For a country like India, which is actually battling tuberculosis, many patients are actually infected. They may remain asymptomatic. But because the patient is going transplantation and eventually immune suppression, this latent tuberculosis will eventually flare up during or after the procedure. Hence, detection of latent tuberculosis is extremely important, especially in the Indian setting. Furthermore, we can also have to screen for various other, like the multi-drug resistant organisms the patient may harbor. If they do harbor multi-drug resistant, post-procedure healthcare associated infections may occur. Next, we do have to analyze the various immunological procedures the patient may have undergone. That is, we may have to note the various vaccines the patient may have already received, and if they have not received, we may have to vaccinate the patient against most of the vaccine preventable diseases, thereby helping us to prevent the infections in the post-transplant period. Now, these are the procedures we can do on the recipient. For the donor, we need to screen for the disease. Most notable disease would include the viral like HIV, hepatitis B and C, which can be easily transmitted with the organ or the tissue transplanted. Now, during the procedure, most of the procedures are surgical procedure, hence proper surgical methods, including the sterility and asepsis, proper use of instruments, maintenance of normothermia, proper use of antimicrobial agents, for judicious use of antimicrobial agents and blood products, and very important is the follow-up of the patients after the procedure. This is very important to prevent the nosocomially acquired infections in the patient. Now, if you look at this chart, now you can find, based on the timeline, we can categorize the various infections and the nature of the infections. For example, in the immediate post-transplant period, we can find the infections mainly due to nosocomial or technical related. Technical related means procedure related, where we can find infections caused by mainly the multi-drug resistant bacteria, candida, and including C. difficile infections. And similarly, after that period, that means from 1 month to the 1 year phase, we can find reactivated viruses. That means viruses which are present either in the donated organ or the patient, they may reactivate. These would include the various viruses or infections acquired from the community. Now, why these are important? Because indeed there are some of the infections which can be prevented with proper chemoprophylaxis. What is chemoprophylaxis? When we actually use certain antimicrobial agents to prevent an infection, that is called as chemoprophylaxis. For example, at present we can prevent infections like urinary tract infections and infections like pneumocystis carinii and toxoplasma and listeria and nocardia with a simple prophylaxis of a drug called as cotrimoxazole, that is sulfamethoxazole and trimethoprim combination. Similarly, in the post-transplant period, we can prevent urinary tract infections with prophylactic use of ciprofloxacin, a quinolone antibiotics. And again, we can even prevent infections with cytomegaloviruses if we can detect it early and use prophylactically ganciclovir or valganciclovir. So these are some of the drugs which can be used to actually prevent infections in the patient after transplantation. So that is what we'll conclude about the post-transplant infections. So what we have actually tried to discuss today is what is actually a transplantation, what are the possible complications of the transplantation other than graft rejection are a very important aspect is prevention of infections, and why these patients are more prone to infections, not only because of the procedure related risk, but also the patients do undergo immune suppressive therapy and other drug therapies which make them more prone for infections. A very important method of identification of these infections is the timeline of the infection. Some specific infections occur more frequently in the first month after the procedure, that is immediately after the procedure, and some infections are more commonly seen from 1 month to 1 year of the time period. So, based on the timeline, we can actually ascertain the various infections. Regarding prevention, we can take some steps for prevention, like some steps what we can do before the procedure, during the procedure, and after the procedure. Before the procedure, we can actually screen the recipient for various viruses, bacterial infections, and latent infections like tuberculosis. We can assess the various exposure history of the patient, including occupational, hobby related, or sexual history. And we can also assess the various immunization, and if we can, we should vaccinate the patient to prevent the infections. A proper and a very judicious use of the procedure and immediate post-procedural time period, if we can prevent the infections with especially use of the proper use of infection control methods, we can prevent many HAIs in this patient. And finally, after the procedure, we not only can use various drugs as chemoprophylaxis, but a very important aspect is to screen this patient frequently, because one thing you must keep in mind, these patients are immune suppressed. So for a normal patient, what we can find various signs symptoms of a particular disease, these signs symptoms are actually subdued in the transplant recipient. Hence we must be very meticulous about if the patient is actually indeed infected, and if there is a very slight suspicion, we must ensure proper use of the identification methods and the various test laboratory testing methods for detection of the infections. And if the infection has indeed occurred, we should use proper use of the antimicrobial agent to cure these patients. Then only we can ensure that overall transplant procedure remains successful and the patient does indeed have a life expectancy which is actually needed in the process of transplantation.